It's a real challenge to step up to the table after 3 fantastic presentations. As you heard, my background, my colleagues think I've gone to the dark side of the force when they hear that I work at the Australian Commission on Safety and Quality in Healthcare. But in reality, I like to believe that I'm still inside me lurks the true beating heart of a Jedi clinician. I work clinically on the floor 1 week a month, and then 3 weeks a month I work at the Australian Commission. It's the Commission for Safety and Quality in Healthcare, and it's a COAG funded body that is, so by COAG it means it's supported both by all of the states and territories and the federal government. We can't do anything unless all of the jurisdictions around the country agree that this should be in our work plan. So everybody has to come together to agree in the directions that we focus, and then we all move forward together. But I come to it as someone who hits the floor and deals with the same frustrations as you do on a day-by-day basis. And so the Commission obviously is about safety and quality for every person, everywhere and every time. Most of you will be familiar with the national standards, and we'll talk about them in a little minute. But what I want to start talking about is end-of-life care, which makes my heart sing, which probably sounds a bit strange. I think Australians are like Americans. As Woody Allen said, Americans like to believe that death is an option. And this is despite what the data shows, that we are, all of us, eventually going to die. And so this is stats for 1,000 years ago, last year, predicted rates for this year, predicted well into the future. We are all eventually going to die. And yet we don't live as if this is the case. And we don't have these discussions as if this is the case. And this is incredibly sexist, but it's my favourite greeting card. Mummy, how come men usually die before women? Well, dear, no one really knows, but we think it's a pretty good system. And, we don't necessarily know when we are going to die. But for a lot of our patients, they'll be diagnosed with something significant that makes that likelihood significantly greater. So as the chap said to the Wizard of Id, do you have anything that stops the ageing process? And he responds, sure, what kind of disease would you like? But deep down, as you saw from that data that Simon showed, most of us have some sense of how we wish it could be. So the poor little chook being carried off to the chopping block saying, and the ones at the front are saying, when it's my turn, I just hope I go quietly without a lot of running around. And for me, I live in Sydney during the week when I'm at the Commission, but I live in Mittagong in the Southern Highlands, and I have a lovely home on a garden with raspberry patch and veggie patch, and if I was diagnosed with this really serious illness, I would prefer to die in my bedroom overlooking that garden and with the trees all around and with my big fluffy cat on the bed nearby and my husband nearby as well. And I'm sorry, I probably got the order of those two wrong. Don't tell him. But most of us have some sense of what we wish it would be. And it acknowledges the human component in all of this. And I love this quote. To say, for example, that a man is made up of certain chemical elements is a satisfactory description only for those who intend to use them as a fertiliser. Because the challenge with all of these clinical scenarios that we've been discussing today is that they have human consequences for everybody. And I can remember when my mum went into hospital a few months back, and the lovely, beautiful intern who was talking to me about Mum's situation was very keen that I as a doctor knew Mum's white cell count and her CRP and all of these numbers. But in fact, the one thing I really needed to know was, how sick is Mum? Is it possible that she could deteriorate and die? I'm one of 6 kids. I've got a bunch of people I need to get in the loop, that we need to all converge on the hospital, and there are things that we would want to say and do if Mum was that sick. And so just to remind you all that death is a human experience. It's not just a negative patient care outcome. And the consequences of not understanding that someone is so sick they may die are significant. Now, about 6 years ago, my mother-in-law died of pancreatic cancer. And she was a ballerina, which is living proof that men don't always marry their mothers. And she, at the end of September, she had sudden onset, really severe abdominal pain. And she presented to a GP, and because, you know, she doesn't make a fuss, she was very stoic. She was Scottish. And so the GP sent her off to have a CAT scan, which identified a really big mass in her pancreas and possibly shadows in her liver, but not confirmed. And so she ended up heading off to have a laparotomy. And it ended up being an open-close laparotomy because the tumour was wrapped around her superior mesenteric vessels. And indeed, those shadows on the liver did actually turn out to be metastases. And so she started her journey with chemotherapy. But in the first conversation with her surgeon, nobody in the ACT, so you don't need to worry, but in that first conversation, and we were talking about prognosis. Now, I'm a palliative care specialist, my husband is a medical oncologist. You probably couldn't have had a more receptive audience to the concept that things might not go well. But the surgeon was talking very optimistically about best case scenario 2 years, most likely 9 to 12 months, worst case scenario 6 months. And so we took that on board, and we took into account the fact that she may respond to chemo or she may not. And we made some plans. So it was the end of September when she was diagnosed, the beginning of October when they operated, and the 1st of November was her birthday. That was goal number 1. Goal number 2 was Christmas. We had a big family Christmas. And goal number 3 was the 17th of January, which was her 50th wedding anniversary. And so as a family, we decided that we would all go on a cruise around New Zealand all together. We had 3 rooms next to each other on the boat, and we had the most fantastic time. But the week before Christmas, I was at a work function and happened to bump into the surgeon. It was actually a university function. And I bumped into the surgeon and I said, oh yes, we're all going on a cruise around New Zealand in the middle of January for the anniversary. And he goes, oh, have you left that a bit late? And my heart sank because I realised clearly, even though he was talking longer term, deep inside somewhere, he was thinking she probably wouldn't do so well and that her functional status might not be good enough to do that kind of thing. And if we'd understood that, we would have done it the week after. You know, the moment her scar had recovered and she was fit for travel, we would have upped stumps and taken that trip because the human experience was what was important to us. Now, J.R. Curtis, who's an intensivist, said the ability to diagnose dying and discuss it frankly and sensitively is one of the most important skills a clinician can develop. And there's evidence that patients who don't have end-of-life discussions tend to continue to receive more aggressive care than patients who do have these discussions. And I have finally got a surgeon here. So Atul Gawande is a general surgeon. He says, our responsibility in medicine is to deal with human beings as they are. People die only once. They have no experience to draw on. They need doctors and nurses who are willing to have the hard discussions and say what they've seen, who will help people prepare for what is to come. People are waiting for us to do this. And patients need to plan and make decisions about the place of death, put their affairs in order, say goodbyes, forgive old adversaries, and be protected from embarking on futile therapy. That's from the Oxford textbook of palliative medicine. You know, the saying goodbyes thing, I think about, you know, there's a group in America called Living Well, and they talk about the 4 things people need to say when they realise that they're dying. Please forgive me, I forgive you, thank you, I love you. In one, you know, it can take 2 seconds if you say them really quickly together, but really, really important for people. And I recognise that it's not easy to initiate those conversations, and it becomes really challenging because, as Simon was talking about, prognosticating can be really, really difficult. And this is a bit flippant, and it might be easier were there ward vultures that would alight on the bed and identify patients. Now, you may think that's ridiculous, but in the New England Journal of Medicine, they have identified a cat called Oscar in a nursing home in America, and I kid you not, Oscar is better at prognosticating than I am. If Oscar sits on the end of the bed, chances are the patient will die within 24 hours, okay? He's still alive. I Googled him last week. Now, my old boss at the CEC said that that's, so a surgeon, Cliff Hughes, used to say that that's because Oscar is a very large and fluffy cat, and if he were to sit in this general region in a frail patient's bed, Of course they'll die within 24 hours, but that's not the case. He sits at the foot of the bed and he presumably detects ketones or something and just hangs out there and he just keeps people company while they're dying. But he's better at identifying people who are about to die than I am, and that's kind of mortifying. And so we need to live and function and make clinical decisions in the space where, you know, recovery may be uncertain. We're going to do our best to try and fix someone. So in this zone of kind of uncertain recovery, if someone is so sick they may die, you know, they may get better. They may turn off to the left and return to their previous function or return to a level of function that's a bit below where they were before, but it's still a reasonable recovery. Or they could continue to deteriorate. And as Simon was saying, we tend to leave these discussions until there's a bit more clarity. And the problem for the patient is if we wait until the patient is clearly actively dying, well, the way we know they're actively dying is because they're no longer able to speak. And so we've waited until the patient can't speak for themselves to actually engage them in a discussion. And so we actually need to be flagging things further up front and having conversations earlier so that we can actually get what's important to them. And as Simon was commenting, you know, there is a presumption of action until there is clarity. So we keep going full steam ahead until it's very clearly no more steam and, you know, make decisions to pull back. And I actually think we have lessons to learn from our obstetric colleagues who live in the zone of uncertainty all the time, but aren't distressed by it. And what they do is they arm patients and families with the tools to work out, you know, like I have never seen an obstetrician sued because someone wasn't born on the day they were due. You know, people don't get upset about that because they're completely comfortable that, you know, the baby's coming when the woman starts having contractions, when her waters break, all of that kind of stuff. Because we've armed people with the tools to work out that someone's deteriorating. And we can do the same thing by having conversations about people's functional status in the context of cancer, or, you know, there's lots of different ways we can look at this. And there are actually some tools. So the Scots have a tool, the SPICT tool, which is actually about identifying indicators for referral to palliative care, which can give you some examples, for example, in renal failure, in COPD, in heart failure. It can give you some clues as to when you might think it's appropriate to refer people. But moving on from there, can you guys confidently say in your hospital that you provide really safe end-of-life care? Is it safe to die in your facilities on weekends, out of business hours, when the patient's been admitted under X, when Y is not rostered on, when Z is rostered on? And we have, as humans, an overconfidence bias, and again, incredibly sexist. An NRMA RACV survey showed that 94% of male drivers believe they're better than average, okay? Statistically not feasible. And the reason it's sexist is because it's 86% of women, so we are nearly as bad. But when we look at the care we provide, we tend to assume that we're doing all right. And yet the data doesn't necessarily always support that. And how can we be sure that the care that we provide is of an appropriate standard? And that's where we come to the National Safety and Quality Health Service standards. How do we, like I'm a taxpayer, and I like to know that my money's being spent responsibly. I don't believe that any of my taxes go to pay for Bronwyn Bishop's helicopters. I believe that they go to pay for hospitals and schools and roads and things like that that are important. They upgrade the Hume Highway, which I have to drive all the time. But we have to be accountable to the taxpayer for the way we provide care in our hospitals. We need to demonstrate that what we're doing is safe and of high quality. And this is where the national standards come in. It's about ensuring that we deliver safe, high quality patient care. And we want to ensure that we're minimising harm, that we're increasing reliability, and that what we're implementing is sustainable change, that we're moving the system forward in a sustainable way. And I saw this on Facebook and it tickled my fancy. This to me is the definition of non-sustainable change. This is I think they call it the 6-minute six-pack. No, 6 seconds. Get a six-pack in seconds, but it's also only going to last for 6 minutes. And it's really not going to be long-term sustained change. And I appreciate it may feel like the national standards were a set of commandments that came down on high and dumped upon you. But in fact, they were actually developed by clinicians roundtables of clinicians actually looking at what are all of the clinical quality issues, where are the incidents, where are the things that go wrong in our system, you know, and where is there evidence that we can do something about them that will improve care. And just to prove that they're not completely fixed in stone, they have actually been revised. So the second edition of the National Standards was released in November last year and will be implemented by next year. And so it has some same standards, so clinical governance, partnering with consumers, HAI and medication safety. The clinical handover has become communicating for safety. Blood products is the same. Recognising and responding to clinical deterioration is the same. But you'll notice this new standard down the bottom, Standard 5 about comprehensive care. And so falls and pressure injuries have been included in the comprehensive care standard, and there are a few other changes that are relevant to end-of-life care. In the partnering with consumers standard, there are actions about demonstrating that we share decision-making with patients, that we actually identify substitute decision makers. Now, I'm not certain on the law in the ACT, but in New South Wales, under our Guardianship Act, we have what's called the person responsible. And I don't know about how things play out here, but clinically in New South Wales, we tend to defer to the loudest, pushiest family member rather than actually identifying who the person responsible is and having conversations with them and then supporting the rest of the family. We tend to bow to whoever's loudest and then appropriate involvement of carers. And then the comprehensive care standard has an overall philosophy, but it also has some actions about end-of-life care. So this is the new comprehensive care standard, which is about ensuring that care is aligned with the expressed preferences and healthcare needs of the patient. So we actually have to get them to express their preferences if we're going to meet this standard. It considers the impact of their health issues on their life and well-being. It's got to be clinically appropriate for their circumstances, and it minimises harm from specific risks. There are 4 criteria in it. The first is about having systems to support clinicians to deliver comprehensive care. The second is about actually developing an appropriate plan of care, and that incorporates integrated screening and risk identification. And we're trying to move away from having 15,000 checklists where you tick everything off, but it doesn't lead to any changes in the care plan. It's actually about identifying what are the risks for this person and what are we going to do about those risks to mitigate them. Your assessment processes, and then developing an individualised goal-directed multidisciplinary plan of care. Then actually delivering that plan of care and adjusting it if it's no longer appropriate to deliver it. And then minimising specific harms like falls and pressure injuries, restraint, seclusion, that kind of thing. And you'll see, I'm very excited with my double thumbs up smiley face emoji, comprehensive care at the end of life. And so there are 5 actions about comprehensive care at the end of life. The first is about identifying patients who are at the end of life. Then the next is about providing clinicians with access to specialist palliative care advice. The next is having a system for advanced care planning so that advanced care plans can be received from patients and are documented in the healthcare record. And then the organisation needs to provide access to clinicians for supervision and support for the workforce that are providing end-of-life care. And then the organisation has to be routinely reviewing the safety and quality of end-of-life care that's provided against the planned goals of care. And then clinicians supporting patients, carers and families to make shared decisions about end-of-life care in accordance with the National Consensus Statement. So you've seen there's a big pile of National Consensus Statements outside. I highly recommend having a squiz at it. And it was developed, again, by a roundtable of clinicians, consumers, managers, policymakers, all coming together. There was a broad consultation process and a significant review of the literature, local and international, and looking at the approaches in all of our different jurisdictions. So what are the essential elements of end-of-life care? It breaks up into 2 different groups. The first is about care that's actually, the care we provide patients, the clinical interactions with patients and their carers. The first is about patient-centred care, that patients are part of decision-making about end-of-life care. That clinicians work together to provide end-of-life care, that clear goals improve the quality of end-of-life care. So we're identifying those goals and sharing them. Using triggers to identify when patients need end-of-life care. And that's both medium to long term, like identifying patients in the last year of their life, as well as identifying in the short term the person who is actively starting to die. And then responding to concerns, the patient who is in distress, whose symptoms are unrelieved. How do we escalate that? How do we ensure that they get the care that they require? Then there are the end-of-life elements for services. And so these are organisational requisites, so leadership and governance, so that you have appropriate policies and systems for end-of-life care, that you have a way that you can get medications out of hours for the person who's suffering. Education and training, so clinicians have the knowledge and skills to provide end-of-life care. Supervision and support, so clinicians providing end-of-life care are supported. Evaluation and feedback, so the quality of end-of-life care is measured and improved. And I was so impressed when I saw your, do you pronounce it ACTASM? So the ACTASM, the Audit of Surgical Mortality, you know, how carefully you are reviewing your deaths. But I wonder, I assume that you're reviewing whether the deaths were preventable, what different things you might have changed in, you know, using the retrospectroscope. But are we questioning, did the person actually have a good death? Because you can have someone whose death was completely not preventable, but they died in agony, they didn't know what was happening, their family didn't know what was happening, they're surrounded by 47,000 people in the emergency department or in a 4-bed room with no privacy, and you know, they have a really pretty horrible end of it all and the family are left completely traumatised. And yet we tick the form saying, not preventable, we feel good. But in fact, they're left dealing, you know, with the human toll of this. So actually starting to consider some of the human components in how we audit our end-of-life care. And then the last is having supporting systems, so our systems align with the standards to improve outcomes. So for example, you can access medications in the middle of the night. So we're actually going to need to look at how we address all 10 of those, okay? So it's a sneaky little thing that's snuck into the side of the standards. We need to actually look at how we address all of those to get through accreditation. This is a picture of what's called the fire falls at Yosemite. And every few years, when the setting sun in the west has a rising full moon behind the falls, it lights up it like it's lava. I haven't seen it personally. It's on my bucket list. But it's one of those things that when the moon is in the seventh sun and Jupiter aligns with Mars, it all comes together in perfect glory. And we have moments in hospitals when we provide beautiful, perfect, excellent care. The problem is, are we doing it consistently? Does every patient get that fantastic experience? And does their family go home resolved that it is awful that I lost my loved one, but I am so glad they came to this hospital, and I am so glad they were cared for by these people who made good decisions or helped us to make good decisions, and we felt supported by that whole experience. So they feel the pain of losing someone, but they don't feel pain related to the care they received. And so we want to do this consistently. We want to make sure that it's every patient, every time. And of course, we'll be checking that it happens for every patient, every time. So accreditation against these actions is going to start from the beginning of 2019. I'm not certain when your cycle is, but it will be coming. And for the palliative care services amongst you, I'd actually point out this is a fantastic opportunity to leverage support from your organisational structures to embed things that you think are important in improving end-of-life care in your local facilities. The other thing is, for the rest of you, you are not alone. You have palliative care services, sometimes on site, sometimes down the road, but you have access to people who can provide support to you. I love this definition of an expert. It's someone who's made all the mistakes that can be made, but in a very narrow field. So we also have support at the Commission. So there's an advice centre we can contact for support with the standards. But I'd like to finish by just saying the French have a really lovely expression that we don't have an equivalent in English. So we can say, she'll be right, mate, it'll all be good, or good luck. But that kind of implies luck, and, you know. The thing is, to do this well, it actually takes hard work and it takes courage. And the French have an expression for that. They say, bon courage, I wish you good courage. My French teacher used to say it as we went into our exams. And so in the same way, I wish you good courage, because it's not going to be easy to demonstrate, you know, like in my own hospital, I stay awake at nights worrying about how we're going to do this for every patient every time. But it's really important. And the best thing is, because when we go back to that data at the beginning, it's going to happen to all of us. So we're building the health service that will hopefully take care of us and our loved ones.